Meeting of the committee to study the safety of residents and employees in long-term care facilities. Before we get started, I'll read through a checklist to ensure that the meeting that we are holding is in compliance with the right to know law. As chair of the committee to study the safety of residents and employees in long-term care facilities, I find that due to the state of emergency declared by the governor as a result of the COVID-19 pandemic and in accordance with the governor's emergency order number 12 pursuant to executive order 2020-04 and its extensions, this public body is authorized to meet electronically. Please note that there is no physical location to observe and listen contemporaneously to this meeting, which was authorized pursuant to the governor's emergency order. In accordance with the emergency order, I am confirming that we are providing public access to the meeting by telephone with additional access possible by video and other electronic means. We are utilizing Zoom for this electronic meeting. All members of the committee and selected legislative staff have the ability to communicate contemporaneously in this meeting through this platform, and the public has access to contemporaneously watch and or listen to the meeting on Zoom or YouTube and via phone by following the directions and links provided on the general court website. We have provided public notice of the necessary information for accessing the meeting in the Senate calendar. We are providing a mechanism for the public to alert the public body during the meeting if there are problems with access. If anyone has a problem, please email remotesenate, that's one word, at leg.state.nh.us or call 603-271-3043. In the event the public is unable to access this meeting, it will be adjourned and rescheduled. Please note that all votes taken during this meeting shall be done by roll call vote. Finally, let's start the meeting by taking a roll call attendance. When each member states their presence, please also state where they are and if anyone else is in the room with you during this meeting, which is required under the right to know law. I will call the roll. Senator Ward.
I am here. My home is started and I'm alone in the room.
Thank you, Senator. Representative Stringham.
Terry Stringham. I am in Lincoln and I'm by myself in an office.
Representative Birch.
Good morning. I'm in Westmoreland and I am by myself.
Good morning to you, Representative. And Representative McMahon.
Good morning, all. I'm at my home in Windham and I am by myself.
Thank you, Representative. And this is Senator Morgan. I am in Exeter and I am very much not by myself. I have my three little boys in the room with me. All right. So I'm going to just pull up the agenda for us, and I don't, we can make a final call at the conclusion of this meeting, but as of right now, I think that our plan is to meet one more time to discuss and finalize our report. And is everyone else on the same page with me there?
Mm-hmm. On the 22nd?
The 22nd would probably be preferable to the 29th, given, you know, current events and stuff. So Alan, Cam, Sonia, is the 22nd is still available. That's correct, right?
Let me just double check for you, Senator. 22nd is still wide open.
Okay, great. So let's plan on the 22nd for our final meeting. And does anyone have a strong preference on time? 9, 10, 9 o'clock work for everyone?
They're all open, so whatever you want.
Let's do 9 o'clock so that I'm not juggling kids and school and this at the same time. And all right. With that, we're going to move into testimony. Is Ms. Buxton with us?
Yes.
We'll bring her in. Ms. Buxton, thank you so much for being willing to take the time to speak with us, share your experiences and your incredible insight. We're very much looking forward to hearing from you, and the floor is yours.
Good morning. Thank you, Senator Morgan and members of the committee for inviting me today. My name is Susan Buxton. I am the New Hampshire State Long-Term Care Ombudsman. I serve on the long-term, I have been the long-term care ombudsman for 4 years. I am a member of the New Hampshire State Commission on Aging. I'm also a licensed nursing home administrator and served in that capacity for many years prior to becoming the state long-term care ombudsman. I would like to begin this morning by sharing with this committee my personal observation about the New Hampshire response to the pandemic as compared to other states in the country. This observation is formed through my participation in the National Association of State Ombudsman Programs, also known as NASOP. This is an association made up of the state ombudsman from each of the 50 states, the District of Columbia, Puerto Rico, and Guam. Throughout the pandemic, NASOP has held weekly calls to review written guidance and regulatory updates from our federal partners at the Administration for Community Living, Centers for Medicare and Medicaid Services, Centers for Disease Control, and the National Institute of Health. We have the opportunity to discuss concerns, share best practices, and seek input. My observation is that New Hampshire has been proactive and provided good support to the long-term care community during this public health emergency. The New Hampshire Department of Health and Human Services, under the leadership of Commissioner Shibinette, has been responsive to the needs for testing, PPE, education and guidance, dissemination of data regarding COVID-19 transmission and prevalence of disease in long-term care settings, and to concerns regarding social isolation of long-term care residents. This has not been the case in some of the other states. The long-term care providers in some states were left to navigate these issues with much less support from their respective health departments. I have read the draft report from this committee that's posted on the General Court website, and I've listened to most of the other testimony. I will not take a lot of time repeating what you've already heard and have included in your report. I will amplify a few points from my perspective as the long-term care ombudsman representing residents in long-term care. Around testing, the surveillance testing of staff and residents was implemented early on and has been successful in detecting COVID-19 early to help mitigate widespread infection. On education and guidance, there's been a weekly call that is open to all providers in the long-term care settings, both nursing homes and assisted livings, with the epidemiologists at the Department of Public Health, the Bureau of Licensing and Certification, the Office of the Long-Term Care Ombudsman, and at times Commissioner Shibinette. During these calls, public health recommendations and guidelines, regulatory updates are provided, and providers are invited to ask questions, allowing for all participants to benefit from the answers. The spirit of these calls was captured in a statement made recently by Dr. Talbot. We learn together, struggle together, respond to each other, and come out with guidance that is for the benefit of these most vulnerable persons. There are typically over 200 participants on this weekly call. What I have heard from some of the other state ombudsmen is that providers have been left to interpret federal and state guidance and regulations individually at the facility level. In some cases, this has resulted in inconsistent implementation and at times poor outcomes. I believe that this weekly call is a best practice by sharing the expertise of our state epidemiologists broadly with the provider community, and has been instrumental in helping to keep residents safe during this pandemic. Data to the public. The DHHS COVID-19 Interactive Data Analytics Dashboard provides real-time information and transparency to the public. This has been an important source of information for the Office of the Long-Term Care Ombudsman in doing our work with residents and their families. So, social isolation. This committee received a copy of the New Hampshire State Commission on Aging issue brief regarding this very important topic. We have made great progress in addressing this issue with visitation guidance issued at the federal and state level, but there is still more work to be done to expand the ability for residents in long-term care to connect with their loved ones in a meaningful way, while also protecting these communities from the introduction and spread of COVID-19. New Hampshire has kept pace with responding to this pandemic with actions that can be stood up in the present time. However, there are also more complex issues that need to be addressed to ensure the safety of residents and to prevent the spread of viruses such as we have seen with COVID-19 and long-term care. Most of the nursing homes in New Hampshire were built over 30 years ago, and few have had any renovations beyond cosmetic improvements. The needs and expectations of residents have changed in that time, and the infrastructure has not kept pace with those changes. This pandemic has spotlighted some of those deficits. The resident rooms are primarily semi-private rooms, and many share a bathroom with another semi-private room. There are long corridors with resident rooms on both sides of the hallway and little common space for people to distance from one another. Staff are providing care to many residents on their shift. These are challenging scenarios for protecting residents from this type of virus. Acute care recognized and began addressing the infection control issue presented by semi-private rooms many years ago and has focused on renovations to increase the number of private rooms. We need to support efforts towards renovations and long-term care to build or renovate buildings to accommodate more private rooms and smaller units. Not only is it important for infection control, it would be a welcome change to enhance quality of life for residents who are living in long-term care. It would also likely improve the working environment for staff if designed to allow for increased equipment used in the care of residents, such as mechanical lifts. One of the national models of care for this type of design is the greenhouse model, which focuses on private rooms, smaller units, and consistent staffing. Research supports the correlation between staffing levels and quality. We hear from residents and staff in our office on a regular basis about short staffing and how it affects them. You've heard from previous testimony that we need to focus on workforce development, and I agree this is a critical issue. You have heard that we went into this pandemic with a workforce shortage, and the pandemic has placed additional pressure on this issue. Supporting wage increases for the direct care workforce and setting minimum staffing levels could improve the retention of staff working in long-term care and should be considered. I would like to bring to this committee's attention the CMS-funded Independent Corona Commission on Safety and Quality in Nursing Home report. I have included the link to this report in my written testimony. This report is organized under 9 principal recommendation themes, within each theme are identified problems followed by recommendations and suggested action steps that could be implemented at a national level. This report could inform this committee in making recommendations for New Hampshire. To my earlier point, you will find within these recommendations that New Hampshire has already implemented some of the suggested action steps. The 9 themes are securing testing and screening capabilities, increasing PPE supply and use, rethinking cohorting practices, prioritizing visitation activities, supporting nursing home communications with residents and families, strengthening the workforce ecosystem, catalyzing technical assistance and quality improvement, enhancing facility design, making data more actionable. New Hampshire has a long history and continues to provide good quality of care in nursing homes as measured by the Medicare/Medicaid survey results and quality measures. New Hampshire long-term care providers have also historically embraced and implemented new quality of care initiatives. I believe it is time to rethink how we're going to provide long-term care in the future beyond just renovating current nursing homes, but also through additional support and different models of care in the community. I'm happy to answer any questions anybody has.
Thank you, Ms. Buxton. Questions from the committee? Representative Birch.
Thank you, Mr. Chair, and thank you, Ms. Buxton, for your information. I look forward to getting the written copy as soon as possible. It's including the link to the report that you just referenced. A couple things in our county, in Cheshire County, we're about 95% through a renovation. We spent a long time considering how much of the greenhouse model to follow and how much not. There were some issues about how much independence that requires versus our population, which is largely dementia related residents. I want to ask you specifically if you have some thoughts about the use of compassionate visits, whether that should be expanded beyond one person being allowed to do that. The outdoor visits are coming to a close due to weather. And it's really a choice now between indoor visits and occasionally a compassionate visit. Do you have some thoughts about that?
I do, thank you. There are two different types of visits. There are actually three different, I'm sorry. So there are, as outlined in the state guidance, there is social visitation, which is began with outdoor visitation, has moved to indoor visitation as well. And while outdoor visitation is preferable because it provides for greater protection from the virus, indoor visitation was set up for those residents that maybe going outside was challenging and also in preparation for the colder weather. There is compassionate care visitation that you refer to, which is really designed to alleviate if there are issues, if residents are experiencing physical or emotional issues as a result of being separated, being isolated, or in the event of end-of-life care. Then there are essential which those are the compassionate care visits can be up to 2 people at a time. And then there are essential support visitation, which is designed really for that person that provided additional support to residents, particularly family members or spouses that prior to the pandemic were part of the care of the residents. So perhaps they came in and they assisted with feeding or, toileting, putting lotion on, those really more in-person support types of visitation. So, and that is one person. So is that helpful?
It is. Thank you for clarifying that. It's appreciated. And if I could just do a quick follow-up, do you find that we're keeping track enough of the mental health, emotional health issues in terms of quantifying how much that has affected both residents and employees, so we can get a handle on the dimensions of the issue?
So I don't think that we currently are capturing that data. I think that it's something we're probably going to look back on and understand better. I think that people are aware of it and are really trying to address it. It's a complex issue as we try to protect from the spread of this virus. But I think it is something that is, we have to figure out how to reconnect people in long-term care with their loved ones.
Representative Stringham.
Yeah, thank you. We've obviously had a number of people here testify. One of the rationales for this committee, or one of the areas of possible inquiry, was the mortality rate in the state, which at the time this commission started, about 6% of those diagnosed in the state succumbed to COVID. And of course, most of those were happening in long-term care facilities. We've really, that rate has actually dropped during the course of our meeting here, which is somewhat encouraging. But we haven't heard anything to say there was anything that we weren't doing right and that we're doing better now. I'm just wondering from your perspective, if you have any comments on that or insights on the issue of mortality and COVID-19, particularly as related to long-term care, and whether anything either changed or anything needs to change. Thanks.
So I think in terms of, are we doing things that has improved that? And I do believe that the testing is has been really instrumental in helping to identify early those asymptomatic, particularly staff members, because we know that's likely how it's entering the facilities, which has, allowed the facilities to respond quickly and prevent the spread. I think that, I think that the actions that have been taking, understanding the virus, the call that I referred to with public health that happens on a weekly basis with the providers, I think has had a tremendous impact on preventing the spread of the virus and potentially stopping, additional deaths. I don't think that we're doing things wrong. I think we're learning as we're going, and I'm not sure if I'm answering your question. Have I?
Well, there's one way to protect our seniors is to make sure they don't get the virus, and another thing is to try to make the course of their disease as non-impactful as possible, whether the symptoms or, of course, they live through it. So I was mainly addressing kind of the live through it and whether that has been an area of discussion rather than just shielding them from getting the disease altogether. And it wouldn't surprise me if it's just a consequence of doing a lot of other things, we haven't heard any testimony to the effect that there's been any substantial change other than high quality care continuing. So that's kind of where I was going. So I think you kind of got halfway there, but it wouldn't surprise me if that's the full extent. I just didn't want to leave it unexplored.
Thank you, Representative. Senator Ward.
Thank you, Mr. Chair. With what we know now and the privacy issues, do you know, Susan, if there are any new long-term care facilities being built with these things in mind of having the individual clients having their own room, being able to have their own bathroom? But I can just imagine from a personal point of view to always have to be in a room with somebody else all the time cannot be a very healthy way of living.
So I would point, I think of the Mountain View facility up in Ossipee, which was recently renovated, and they are built with a greenhouse model. They are primarily private rooms, and I would point, I think we can look to, they had a recent small outbreak. I don't remember, I think there were around 5 individuals between staff and residents, and that outbreak really didn't go any further than that? Can we draw from that the conclusion that the physical infrastructure helped to prevent the spread of coronavirus? Perhaps. I'm sure there's also other things I'm sure that contributed. That's one that I'm aware of.
So follow-up question.
Please.
So in any of the other long-term care facilities, as they are being remodeled, is the one room per client taken into consideration then?
I don't think that there's a lot of renovation that's happening. I don't think that the long-term care providers are in the financial position to be able to do that. I think that there is cosmetic renovations that are happening. I think that we see that there are some units where they have more private rooms for the Medicare skilled residents that are short-term and are reimbursed at a different level, but we're not seeing a lot of renovation of long-term care beds.
Okay, thank you.
Ms. Buxton, Representative Birch, I'm sorry, go ahead. You're muted, Paul.
Thank you. Two quick things. One, the remodeling of the county nursing home in Cheshire County will have mostly private rooms for all the nursing home residents. It was something that we paid a lot of attention to. My question to Ms. Buxton has to do with whether you have any thoughts about getting more activities people back into the facilities to get some normalcy going in the lives of the residents. Seems to me, and I have a question about this, if we can have staff that comes in, gets the temperature check and the questions and the like, what's the impediment to having people who play music or run bingo or things like that come in and try to get some normalcy back into the lives of residents?
I would support that. I think that is really the direction of our public health department to weigh the risks and benefits of reintroducing additional people into the long-term care setting.
Ms. Buxton, a couple of questions. One of the recommendations or thoughts that we've heard from other presenters, as you're probably aware, is discussion around mandatory employee testing. Could you just speak a little bit about how you would perceive both the pros and cons of that kind of a policy?
I'm not, it's a little bit outside of my area of expertise. I think that it varies across the providers. I think there are some facilities where they have a really high participation. I did hear the testimony where the commandant talked about the veterans home having a lower percentage of staff agreeing to be tested. It's certainly a great tool in the toolbox to prevent this virus from infecting residents in long-term care, and I'm supportive of testing as many employees as possible.
Okay, thank you. And the only other question I had was, we talked about Senator Ward mentioned that it's not a healthy situation, and I think we can all acknowledge that when you're having to share a bathroom and a room with folks. And so the idea of having singles be so important. But you also mentioned that this might be tied to reimbursement rates at a certain level. Could you just go into a little bit, and I'm sorry about the kid noises in the background. We're dealing with that. Could you just talk a little bit about what we could do in terms of policies that would make it so that we could get to that healthier place of having more individual rooms?
Well, I mean, it is tied to the reimbursement rates for long-term care.
So increased rates would likely lead to healthier outcomes and quality of life.
Yes.
Where we're going. Okay.
Yep.
Great. Thank you so much, Ms. Buxton. Any further questions from Cam? You're not on the committee. Sorry, Ms. Buxton, go ahead.
I would add to that, looking at also, is there opportunities to rebalance the system also to provide additional supports in the community? That is something that we hear from residents it is sometimes challenging to be able to help residents to transition to a community setting without additional supports.
Sorry, Dad.
Thank you. Cam, did you have something to?
Susan, if you can just send me your written remarks, I'll get them out to the committee as soon as possible.
Okay, great.
Thank you very much, Ms. Buxton, for joining us this morning.
You're welcome, and thank you for inviting me.
All right. Looking to the agenda, I believe we had some time set aside to discuss the final report. Is Commissioner Shibinet here with us? I don't want to take up her time.
I don't see her name on the list.
Okay.
There are a few people on the phone though. Cam, do you know how she was going to join?
I thought she was going to join via Zoom.
Okay.
I don't
Let me just say, Commissioner, if you're one of the folks on the phone, if you could press *9. I don't think she's with us yet.
Okay. Committee members, if you all read, you've all received, have you all read, had a chance to skim over at least the draft report?
Skim over.
Thank you, Senator. Any insights, comments, thoughts regarding the report? And I think the most helpful thing for us to do would be to discuss the final page. Of course, I welcome comments and input about any of it, but the final page regarding the findings and recommendations.
If I may offer one thing, Mr. Chairman?
Absolutely. And actually, Representative McMahon, Senator Ward, if you would just take charge for 2 minutes. I have a childcare situation.
Okay,
Thank you so much. I'll be right back.
sure.
Senator Ward, Charlie McMahon speaking.
Yep.
In reading the draft report and just going on back on my learning a lot from those at Health and Human Services, CMS plays a major role in how New Hampshire provides for its senior citizens in terms of these services. In terms of reimbursement rates, I found that we're dealing with what I call faceless bureaucrats who will never see that make a big decision on funding that we would then match in the state. In coming to a number on this, what I haven't heard from the testimony so far is, I don't think it's come up, is what additional funding should we advocate for in working with the bureaucracy where CMS plays a major role, and in terms of increasing the funding request that would be approved in Washington.
Well, I wonder if Lori Shibonette would be the person to answer that question.
Right. Oh, well, just in closing, I just broach it for us together as on the committee here, is I have found that to be the primary mitigating factor in advancing home and community-based care funding,
Right.
not just in our nursing and assisted living, but so that our elderly, or I call aggressively mature individuals, can stay in their homes longer.
You mean with maybe perhaps the care of their family, that their family members will be reimbursed for taking care of the elderly person in the home?
That could play a role, but the main thing, one thing I brought to the legislature 2 terms ago was increasing DSP, direct service provider wages. It wasn't successful, but maybe it's a new paradigm being this with the pandemic. I'm curious if the other committee members would think it would make sense to have that part of our recommendations.
Okay.
In that regard, that's what I wanted to offer.
Okay.
What was the funding mechanism for that, Representative?
There would be a CMS plays a big role in matching funds in providing for in-home care, and it's a matter of just how it's working with our infrastructure within the Department of Health and Human Services, and then you advocate directly with Washington on how much they'll send to the state of New Hampshire for various silos, as I call them, but for these purposes, so that we can keep people out of the nursing home. And just I'm in Rockingham County, our costs are 120, 130 grand a year versus approximately, and this is just my own bias, between 40 and 50,000 a year with in-home care. And so that I want to see if a committee would support that, the recommendation being to work with CMS and the department to increase not just, and it's referred to in our number 10 in our recommendations, on what a so-called living wage is. The wage should be what would attract someone to do this kind of work and to be qualified to do so, and meaning the DSP, a direct service provider.
Well, Representative, I for one would be very supportive of moving in the direction of a livable wage to both attract and retain staff at our long-term care facilities. And I'd be happy to, would love to hear what the rest of the committee thinks, but I also think that's an important question to ask Commissioner Shibonette, her perspective on that, given her expertise in.
I was looking at, excuse me, I was looking at number 10, and I don't, I have a hard time thinking about people working in healthcare and being paid the minimum wage. But they are professionals and they should earn a decent living. But I think from my experience in New Hampshire, healthcare personnel has never really been appreciated for what they're doing. And to even talk about a minimum wage when you work in healthcare, I think it's just not the right thing to do. They should have a wage that that supports them and also supports the number of people that we are able to employ. So I think the wage for healthcare workers is just way below what it really ought to be.
Oh, I firmly agree with that, Senator Ward, and I'm thrilled to hear you say that. I agree. I don't think that our healthcare workers should be paid a quote minimum wage. So I don't think that the discussion is necessarily around minimum wage, but I think healthcare workers should be receiving a livable wage, period. Right. And I agree with you that our healthcare workers are not appreciated for the benefits that they provide us, especially given the fact that we're the second oldest state in the nation.
Right.
And Mr. Chairman, I'll offer just one more comment.
Please, just this open discussion between the committees. We're until we hear from Commissioner Shivenett.
I didn't want to get in the way of Mr. Representative Stringham. I just one more comment was the research I had done was there was a understood but not in black letter law cap of $15 an hour for direct service providers providing care in the home, and that is something that is not attracting more folks to participate. And when I did my own research on it, I've been on Health and Human Services for quite a while. It was people choose to do nothing until it affects them directly. And this pandemic has really brought this home. And so I wanted to just ask, not right now, but if the members would consider maybe supporting an effort that a express or implied cap, it's not in black letter law, but it has been the function that I've learned in the department of a $15 cap be changed, frankly, so that we can attract more people into this service and thereby save dollars by promoting in-home care.
Mhm.
So that was my concept, and after looking at some very good recommendations that are being made as a product of all the good work of this committee. But thank you, Mr. Chairman.
No, thank you, Representative. And Representative, I would invite you to either alter the wording of number 10 or somehow put in the specific language that you would like to see, so that our committee can all put this forward and hopefully with unanimous support.
In terms of,
Representative Birch, go ahead. Yeah, just again, open discussion, please.
Jerry, go ahead first.
I was going to follow up Senator Ward. You know, I think the marketplace is also supporting your contention that healthcare workers are underappreciated. When you have chronic, 25% seems to be the numbers that we're kind of hearing of shortfall in terms of number of workers compared to the number of nursing type workers that these facilities are saying they need without severe risk of burnout of the employees they have. And the question is why aren't those type of market dynamics working? Why aren't these facilities feel comfortable charging or attracting people with wages that actually fill the positions? And it's because the economics don't work overall. They end up closing wings or reducing the services they provide with shortfalls rather than boosting wages. I think the testimony in terms of staffing that we've heard is that there's still acute issues related to the pandemic that we can address or at least be supportive of. We know family care issues are significant, particularly when children are having to be at home for school, such as or young, like Senator Morgan's children, and the risk of their own health is somewhat more severe. So we've heard some wishes to at least have some temporary relief to get through the pandemic. I had conclusions in some other areas of inquiry that the PPE, we still have periodic shortages of things like medium gloves. We have issues of price gouging without mechanisms to respond to that. The testing, it seems like the instant testing that has been brought in, while a good idea, was kind of a miss because it's just not accurate enough to be reliable. And the other testing is extraordinarily expensive and slow. So that is exacerbating the isolation problems. You know, there's a real need for cheap, accurate, you know, fairly quick testing, and that can be rolled into the isolation, you know, to allow us to be more comfortable opening up these facilities more. I think the newest issue is whether these facilities are designed for the needs of the people that we have now. That might be a longer term issue that I appreciate Susan Buxton going into detail now. So those are kind of the buckets that I was putting the different testimony. The only other thing was the mortality, which was somewhat of a dry well in terms of is there anything that we can learn from New Hampshire's high mortality rate as a percentage of those either in long-term care of the total or of our death rate, and I haven't heard any recommendations that way. So that's kind of my thought and how I would organize these 10 recommendations are in there, perhaps with 1 or 2 letters.
Great, Cam, did you get those down, especially the PPE one? And then Representative Birch.
Thank you. I hope that we, without any disrespect to what Representative McMahon has suggested, because I know in Cheshire County, we've spent a lot of time trying to figure out how do we keep people home from both a human perspective and from a financial perspective. Care at home is better than in care in a facility. But I think our mandate here is not really about that issue. And I want to make sure we try to stay on our mandate, which has to do with the nursing home and long-term care facilities. I'm particularly concerned about the issue of testing because I think in real life, testing has gotten less and the costs are being shifted or shift. And both of those concern me. And the testing has been both of residents and of staff on a somewhat fairly frequent schedule. The plan is to drop the testing of residents for reasons given, and also have the costs at least partially paid by the nursing homes themselves. And I've got some questions about both. So I think that at a minimum, I would hope that the state would continue to pick up the cost of the testing out of funds that either CARES money or PPE money or whatever the money is, and not have that burden at this time placed on the nursing homes. So I think we need to address that. I'm interested. Yeah.
If I could just ask you to hold that thought, and we'll come back to it after our next presenter. But I see that Commissioner Shibinette is with us, and out of respect for her time, and just grateful that she's able to share her perspectives with us this morning. Would just love to hear from her, because I know that she has an incredible amount on her plate right now. Commissioner, I believe you can hear me, and I just want to express my gratitude and the committee's gratitude for you taking the time to be with us this morning on this incredibly important issue. But during what we all know is a time where probably it's still all coming at you like a fire hose. So thank you so much for being with us, and the floor is yours.
Thank you. So, you know, I really, my intent today is really to answer questions. I did hear some of Representative Birch's comments, and so I do want to talk about testing a little bit and what we're seeing. patterns and trends, what's going on a federal level, and what our plans are for state level.
Commissioner, your audio is pretty choppy. Are you on a
Laptop.
You're on a Bluetooth? You're on a laptop. Okay. Well, we'll just keep plowing ahead, and we can hear you. It's just a little choppy.
So hopefully it'll get better. So since back in May, directed testing with all of the nurses across the state. Our program really is around testing the staff. That's who brings COVID-19 into our buildings, is the staff. Most of the residents don't go out. If they do, it's very minimal. Residents that come in as new admissions come in into a quarantine state.
Commissioner, I'm sorry. I think we're just having a real hard time.
Why don't I
hearing
try
you.
calling in?
Yeah, let's do that.
We can
Cam,
promote you. If you call in, Commissioner, we can get you back up here.
Okay, so just give me a minute. You guys can keep going until I can get.
Sure. Thank you, Commissioner. Representative, I don't know if you wanted to continue, Birch. No. Okay. All right.
You want to approve the minutes for the last meeting while we're waiting?
Yeah, should probably do that.
I move that we approve the minutes from the October 8th, October 8th, 2020.
Do I have a second?
Second.
Moved by Representative Stringham, seconded by Representative Birch. Thank you both. And Senator Ward, your vote, please.
Yes.
Representative Stringham.
Yes.
Representative Birch.
Yes.
Representative McMahon.
Yes.
And Senator Morgan's a yes. Let's just give Commissioner Shiven a second.
Just a reminder, Mr. Chair, that I will be leaving in a few minutes for my next meeting.
Senator Ward, are there any issues that or questions that you would like to ensure that the committee raises with the commissioner?
I would like to find out exactly what can be done with the reimbursement for some other services.
Okay, we'll make sure that we ask that question and
Okay, thank you.
Get back to you.
I'm on the phone, so.
Perfect. Perfect.
Great. You can hear me better now.
We sure can. Thank you very much, Commissioner.
So as I was saying, state testing program started back in April, May, right around there. And our program, this was prior to the federal government coming out with any type of recommendations for testing around nursing homes. So we started our own program. So we're doing every 10 to 14 days, 100% of the staff. At that time, it was voluntary before the federal government required it, and 10% of our residents in each facility. What we saw through the summer months is largely when we did detect a positive case, it was in the staff. Once we had one positive case at all, we went through and we tested 100% of all residents and all staff again. And then we serially do that every 5 to 7 days while they're in outbreak mode or in monitoring mode. Throughout the summer, it became difficult for many facilities to be in our testing program because when we're testing 10 and 12,000 people a week, trying to schedule that, we need to schedule it 7 days a week, pretty much 8 to 10 hours a day. And so when a facility got kind of their straw got drawn to be tested on a Saturday, they would have to call in all of their staff, everybody into the building on that Saturday to get tested. It became very burdensome to them. We initially went with Mako. Mako had a great online portal. There's always bumps that you hit when you're starting up any program. They were getting some false positives when we were at Mako. The facilities requested that, that I shift to a different lab. We did that. We still had scheduling issues and just the need, the average turnaround time being 2 or 3 days. There are always outliers to that. So a facility may get, if they're testing 200 people, they may get 190 of those test results back in 48 hours. And then, 10 could be lagging by another couple of days. That became very frustrating. In a lot of ways, what they wanted to do was a self-directed testing program. They wanted to decide who to test, when to test, on what day of the week to test. And through those discussions, what I ended up doing was saying, we can do this and we can pay for it. We are paying for the program that we're asking them to do. So we sat down with the public health team, decided, what is the CMS requirements? The CMS requirements are every 28 days, staff only. What do we feel is necessary? What type of testing? So CMS came out about a month ago. They sent antigen-based machines to all the nursing homes. They directed the long-term care facilities that they could use the antigen machines to do surveillance. We did not feel that was sufficient. So when we moved to a self-directed program, what we said is we'll pay for testing of 100% of your staff every 28 days, and then a subset of your staff, 10% every week outside of that week that you test your entire staff. If you even get one positive case, we will come in and we will test 100%. If you need testing in between that, or if you don't feel that's sufficient, you can use your antigen test. So that communication, and so then every month they log the tests that they do. They send an invoice to the state. We pay them $100 a test. Now, our average amongst all the labs are about $100. We pay $65 for some, maybe a little over $100 for some others. What I've been told from my team is that most nursing homes are able to contract at or under $100 a test. So I think it is paying for everything that we're asking them to do. It was definitely scary, right? Moving from a system that is being directed by the state. It is very organized. I have a team of people doing it. They're told when, where, who, and it's very organized. Moving into a system where they're responsible for determining who and how often can be scary. But we've literally been, hand-holding and working with them every step of the way, helping them get contracts, connecting them with the labs. And I think for the most part, most of them are going to be contracted in the next week or so with a commercial lab that will give them the flexibility to test when they want, so that if their best staffing day is on Wednesday, which long-term care usually is a Wednesday, they can decide to test their staff on Wednesday. If the day they typically test falls on a holiday, they can switch that day to another day. It gives them that flexibility. What that does for us at the public health lab in our contracts is it gives us the flexibility to test more than just nursing homes. We had about 85 to 87 nursing homes on our surveillance program. And last month we added in assisted livings in Hillsborough and Rockingham County. They have also had outbreaks in assisted livings. We wanted to add the other assisted livings and then other facilities like homeless shelters and community residences that serve people with disabilities, things like that, which we did not have the capacity in our program to do that if we were doing our directed testing every 10 days on every nursing home staff. So that's where we are with testing in nursing homes. I think it is scheduled to start next week, but we're giving a glide path off into that self-directed testing. It may take several weeks. We don't have a hard and fast date. If someone can't get a contract in the next 2 weeks, then we'll work with them until they can. This is not us kicking them off a program. This is us helping them get to a program that has more flexibility built into it for them. So other things that we're doing with it, so back to testing, as soon as they get a positive, it comes back to us. So, as they're doing the surveillance, if they just have one positive test, then we take over from there and we do the testing for them. Other things that we're doing in long-term care, we have a contract for outbreak staffing. So we staff buildings that have outbreaks that lose staff due to quarantine or isolation. We have a contract with interim healthcare. We've done hundreds of hours of putting our staff in place. We are supporting probably about 6 facilities right now, some of them in outbreak, some of them just out of their outbreak, so that when they lose their staff, we send our team in to supplement their staffing. So that's been in place since about May. I think that's really all I have outside of questions, because I know that I want to give lots of time for questions, and I can touch on other things as you'd like. I think what we're seeing, as a pattern right now, we have less nursing home outbreaks than what we did in May, June. We're better positioned now than what we were in the spring. We have plenty of PPE. There is no nursing home that should be reporting that they're short of anything. We had a period of time in the last couple of weeks where we had a shortage of large size gloves. Outside of that, or we have plenty of masks, N95s, gowns, gloves, anything that they need. Everybody that has put orders in have had them filled. So there should be no shortage of PPE at all. So I think, we're in better position for PPE. We're in better position for testing. So I think we're in a better place to handle it. And I think what I'm seeing now is, back in the spring, what we saw with outbreaks is we would see them creep over several weeks. They'd get 5 cases, and they'd get 10 cases, and they'd get 20 cases, week after week. And what we're seeing now is, because we're so efficient in our testing model, is that we're going from 1 or 2 to 30 in 1 week, because we're able to test everybody and have a turnaround time of 2 days. So I think that's largely because of the testing, but it's definitely an interesting trend, because, this week, every week I announce outbreaks at press conferences. And what, I remember very clearly where I would be announcing outbreaks and announce 5 new cases, 7 new cases. And, last week I announced 30 new cases in a facility. And I think that's largely due to testing. And I'll be doing the same today on another outbreak that we have. So I'm going to stop there, and I know there's probably a lot of questions around testing, so I want to be able to answer some of those.
Great. Thanks, Commissioner. Let's open it up to questions, and I do have a question from Senator Ward, but I'll hold on to that in deference to the other committee members for now. Questions?
Sure.
Representative Birch.
Thank you. And thank you, Commissioner, for the work that your office and you have been doing over the last number of months. It's greatly appreciated. Part of our concern here is the ongoing issue of social isolation. And there seems to be a growing sense of hopelessness among family members and among some residents that COVID's not going away anytime soon. These restrictions are not going to go away anytime soon. The opportunity for outdoor visits is going to be lessened due to weather, which leaves indoor visits and some forms of compassionate and essential visiting. Do you have any thoughts about how you project the issue of contact and interaction over the next number of months, and how that could possibly be increased? Also, the issue of how do we get more people from activities to be able to get into our facilities and help residents get some normalcy back in their lives?
So when it comes to family visits, there are 2 components here, both the federal restrictions and the state restrictions, and we lifted restrictions on visits like probably a month ago. So facilities right now, if you're not an outbreak facility, once you're an outbreak, visitation's not allowed. That's not new to COVID. That's been around forever. When we have flu outbreaks in facilities, the facilities close down for visits. The difference is flu outbreaks last maybe 4 weeks, 3 weeks. It doesn't last 8 months. So back almost a month ago, we did a phased approach, phase 0 being an outbreak, then phase 1, phase 2, phase 3. Phase 1 being compassionate care visits only, phase 2 and 3 having indoor and outdoor visits, but limiting the number of visitors. All of the counties were in phase 2 until about 2 weeks ago. Now we'll probably be announcing 3 counties in phase 1 now. But, the federal government has been very clear with nursing homes that they are not allowed to restrict visitation for their residents unless they can show that there is a significant safety or COVID concern. So that would include being in current outbreak, right? You don't want people visiting if they're in current outbreak. But outside of that, compassionate care is very broadly defined. And it's not just hospice care as what we originally thought. So at this point, any facilities that is not in an outbreak status should have a visiting program. They really tried to do outdoor visits all summer long, and that was very appropriate. That is the best case scenario for visits, is to do outdoor visits. But everybody has known that as we're coming on colder weather, we need to switch those to indoor visits. So unless they're currently in outbreak status, or they can show some other very significant risk to their residents, they should all have a visiting program for indoor visits. And I've heard that consistently. I have family members contact me daily, multiple family members, and many of them believe that the restrictions that were put in place were put in by the state, and in most cases they were not. The federal government really came out with the restrictions. CMS, which is the federal agency that oversees nursing homes, came out with the first set of guidance. We backed off the federal guidance about a month ago and said, we need to move towards, I wouldn't say normalcy, but that psychosocial priority for our residents. I worked in nursing homes for 20 years. Quality of life is the priority for every nursing home resident in this state. And most of those residents would not define a good quality of life as being isolated from their family and friends. So moving in that direction, I think that things loosened up a lot a month ago. I think that the federal government in the last 2 weeks has made it clear that every facility needs to have a visitation plan. I think as this extends onward through the winter, you're going to see more need to loosen things up so that the residents can have visits with their family. So, in most cases, people will say it's a choice, right? I'm a resident of the nursing home. I am choosing to, knowing my risk, to have my family visit me. The problem that we have is that in most nursing homes, you have semi-private rooms, right? And although it may be your choice, if you get exposed to COVID, you have now basically going to expose your roommate to COVID. And maybe that resident and that family is choosing to self-isolate. And that is inherently the issue, is that because it's close quarters and congregate living, one person's choice impacts everybody in the building. So it's trying to balance that, the resident's right to have access to their family, and then the resident's right to be safe in their environment. And that's the balancing act.
I could follow up. I understand that balance, and it's an important balance. And at least in our county nursing home that I'm quite familiar with, the balance is in favor of safety, and I have no quarrel with that. What I do hear from time to time is not enough staff, for instance, to handle the number of people who want to come and do indoor visits. Those kind of resources. Is there space segregated for those that aren't a private or semi-private room? And if so, the cleaning that's involved after each visit and the like necessarily limits the number of those visits that can happen. So I'm wondering if you're getting any information about the balance between requests for visits and the ability of nursing homes and long-term care facilities to handle those requests.
Yeah, I think that it was certainly easier when the visits were outdoor because you could space people out on a lawn or on a patio and things like that. It becomes more of more labor intensive when it's inside to have a large space that meets the 6-foot social distancing and things like that. So I have heard from some families that have said, you know, yes, my mother's in a nursing home that's allowing visits, but because of the staff time that it takes, I'm only allowed to visit once a week. I have heard that for families that are accustomed to visiting every single night, once a week, although right now felt good, it's not going to feel good in the coming months because they're very involved in the family life. And this is especially true for spouses, right? So we hear more about husbands and wives that, you know, that didn't get to see their spouse for several months and have now is now only able to visit once a week. So yeah, I definitely do hear some of those concerns coming from families, and I would encourage facilities to find more than one space, right? And I think that is part of the key. Is like a lot of facilities will take a conference room and say, this is our visiting room. And that's not necessarily the only way you can do it. You know, I know a facility that has a bigger space, like an atrium, and they have set up tables 6 feet apart around the atrium so that they have one person supervising 6 visits. That allows more families to get more access, and you know, one person can supervise, one staff person can supervise multiple visits. So thinking of activity rooms and things like that to try to get that 6-foot distancing and have more than one visit going on at one time.
Looks like you have something else on the tip of your tongue, Representative.
No, I was just thinking that that last idea was a great one. I was visualizing the space at Maplewood in Cheshire County, because right now the visits are in a regular small little room, but there are some huge conference rooms. And I guess at the end of today, I'm going to go check in there and see if that's being considered. So it was nice to hear that.
So, yeah,
thank
you. We've seen facilities put up partitions between the tables so that you still have a designated space. You don't have people walking through that area during visiting times, and you see tables with partitions up between the tables 6 feet apart so that you can have multiple visits going at once. If that's something that they're able to do, because you want to give the privacy to the family and the residents too. The need to supervise a visit is supervised at a distance, so you don't have to be sitting at the table with them, right? You want to give them the privacy to have a good visit.
I'm wondering, since I don't see any other hands, I'm wondering if
I have 5 questions.
Oh,
so you take your time.
This will be my last.
Right.
I'm wondering if there's any way that you have to quantify the issue about the mental health and emotional health of the residents. I know reports are kept endlessly of everything that goes on in a nursing home because of federal and state requirements and the like. But is there any way that we can get a handle on the dimension of the problem of social isolation in terms of mental health, emotional health of residents and staff?
I think eventually we will be able to. So as you know, and as you referred to, everything about our residents are captured on what's called the MDS in nursing homes. It is a very long assessment that's done every 90 days on the residents. And on the MDS, it does ask questions about mood, such as depression. I think the other thing that people have seen and families have reported is that people that have dementia or Alzheimer's disease, what they're seeing when they go in for visits is like this deterioration of cognition because their loved one isn't engaging in their community the way they did prior to COVID. So I think it would be interesting to see, and I don't know how readily we could do this now, but I think it's definitely something that we're going to look at retrospectively, is what is the average score when it comes to mood and behavior on the resident MDSs pre-COVID, post-COVID, or during COVID, and then did we see a cognition decline that is different than what we saw pre-COVID? Those are two very good questions. I think you're going to see most likely the federal government do a lot of that data collection. We may be able to do it at a state level, but right now 100% of my resources are COVID related, so I wouldn't be able to pull like my data analysts off COVID to put them on. That's a very hefty project they would need to commit to.
Thank you.
Yep.
Representative Stringer.
Yep. Since you have 5, I'll try to keep it quick. I thought we had heard some testimony. I'd have to go back and look at the notes that some of the centers are expecting to pick up more of the testing costs or themselves. How long does your funding to support testing, and is it 100% of the nursing home needs? How long will that continue?
Right now, we've budgeted out through the end of this calendar year, but if we go beyond that, which I expect that we will most likely, we will be looking for other funding sources. I think the concern was early on was that they did not feel like they could contract with a lab for $100 per test. And what I've heard from my team is that most labs are right there at $100 or less. I think facilities so right now, when they do testing, that means the facility does the specimen collection, they swab the staff, and then they send it to the lab. If a facility chooses to contract out for that specimen collection, so let's say they ask a VNA or an urgent care to come to their building and do specimen collection and send to a lab, that is going to be more than $100, but every nursing home in our state has the capacity to do specimen collection themselves, so that would be a choice. If they do testing beyond what our recommendations are, that would be a cost to them. Their antigen machines that were sent to them by the federal government was sent with enough supply, minimal amount of supplies. They are responsible for buying those cartridges, but the federal government did do relief packages for nursing homes in New Hampshire, at least 2 rounds of it, and we've had at least 1 round at the state level. I think we've had actually 2 rounds.
Thank you for that. Totally separate question. This committee hasn't delved much into mortality, but one of the reasons this topic was of interest was because of the high percentage of fatalities due to COVID that occurred at nursing homes, and then the overall death rate, which beginning of the commission was at 6%. Is there anything that either happened or that we have learned that would be appropriate for this commission to understand of why we had a kind of higher than normal death rate in New Hampshire? Or
we did. So I think part of what you're hearing is certain media outlets picking a data point and running with that data point, right? So yes, 80% of our deaths were in long-term care. When you look at our overall death rate by nursing home licensed beds, it's far below most of our New England states and many other states across the country. So you look at the percentage of nursing home residents that we lost, the number of nursing homes that have had outbreaks. I put that data up at our news conferences on a pretty regular basis, because when you have low community-based deaths, right, which we have in New Hampshire, and then you take a percentage of them, it doesn't mean we have more nursing home deaths than anybody else. It just means that, of our total deaths, most of them are nursing home because our community-based death is low. The only way to change that percentage is to have more people in the community die, which I don't think anybody wants. Right, and we're certainly not aiming for that. So our goal is to overall is to keep the number of outbreaks, because what we do know is that when COVID gets into a facility and there's evidence of transmission into the facility, stopping it at that point is very, very difficult. So we have had several facilities that have had one case or two cases in their staff, maybe two staff that are household contacts or friends outside of work, and we managed to catch it before it got into the resident population, and they never ended up in like an outbreak status that I announced. Once there's evidence of transmission within the resident population, it becomes so difficult because there is no opportunity to do 6 foot social distancing when your caregivers need to provide care to you. So the goal is to stop it before it gets in. And the nursing homes are doing everything that they need to do, right? They're doing all the pre-screening, they're doing the testing, they have sufficient PPE. So, you know, there's a ton of education that has gone out. We have surveyed every nursing home in this state at least once, sent a survey team in to do infection control surveys. Everybody's been done at least once. Several have been done more than one time. The federal government has a federal team that they send into hotspot nursing homes to come behind us to make sure that what we're doing is correct when we audit these facilities. So I think, you know, what we're seeing in New Hampshire is not different than what we're seeing across the country, that the people that are at most at risk for mortality and even morbidity is our people over 65, 70 that have underlying health conditions. And, you know, every single resident in a nursing home has an underlying health condition because they wouldn't be there if they didn't, right? So, you know, without a doubt, you know, whether it's a cognition issue like Alzheimer's or dementia, or it is your congestive heart failure, you know, chronic obstructive pulmonary disease, that is braided all throughout our nursing home population. So they are the demographic that's going to have the worst outcomes in COVID-19.
All right. Thank you, Commissioner. Commissioner, my first question is around the idea of mandatory testing for employees. And so I've heard both during the testimony we've heard in this committee, but also in other conversations, some competing perspectives on, do we have mandatory testing? Who is paying for it? Are some employees feel like if they're being told it's their responsibility to get the testing on their own dime? And I would just, could you just clear up for us? And I know you spoke about it a little bit at the beginning, or you spoke about it at the beginning. Do we have mandatory testing in our
the entire
for our
country has right. So the entire country has mandatory testing. The federal government has required all nursing home employees to be tested. I'm not sure of the time frame. It is right now our time frame in New Hampshire is 28 days and that's what the federal government has put out. Other parts of the country are different depending on their positivity rate in their area. But yes, the federal government has required. We are paying. The state is paying for nursing home, all 100% staff testing every 28 days. So if the facility is passing that on to the staff, it's unnecessary because we are paying for it. That's for nursing homes. So I have heard that in assisted living that there is some of that going on. And one of the reasons why we're moving nursing homes to self-directed testing is so that we can make room for assisted living on our program. Only Hillsborough and Rockingham County have been on our program for the last month, but once starting in 2 weeks, we're bringing on more counties, so all assisted livings will eventually be on our 28-day program.
And what are the consequences of employees who refuse to be tested?
I think the employer deals with it a little bit different depending on who they are, but what I've heard across the board is that the employee is not allowed to report to work until they have submitted a test. So one of those circumstances that you referred to, an employee being told that they have to test, that perhaps they missed the testing day at the facility. And I've heard about this a couple of times. So when we were doing the testing, the state, and we said testing is on Saturday, right? And that employee was on a week-long vacation out of state somewhere on that Saturday, the employer may say to them, before you come back to work on Monday or Tuesday or whenever you're due back to work, you're going to have to get a test because you missed our testing day. And so they have to go to either one of our testing sites or wherever to get it. Now, every citizen of New Hampshire has access to testing. There is no shortage. We have probably 40 plus places right now that have testing. If you don't have insurance, we have coverage for you through the Medicaid program. The health insurance companies are paying 100% of the cost of the test without copay, without deductible. So no one really should have, unless you are private pay because you're extremely wealthy and you don't qualify for Medicaid and you don't qualify for any of the programs we have, or you choose not to fill out your insurance information, which is the other thing that's happened several times. You should not be getting a bill for just a test. What happens sometimes is that someone that is symptomatic will go to the doctor. And this has happened several times. So I'm sick, I have a cough, I have a sore throat. I go to the doctor does an exam on me and says, I think it's strep, but I'm going to test you for COVID. The patient believes that they are there for a COVID visit, right? And then the diagnosis come back that you have strep throat. The insurance company processes that as strep throat. So if you had a $30 copay for your physician's visit, you're going to have a $30 copay because you went for your diagnosis in your insurance is strep throat, not COVID. So that is where some of the confusion is coming in, is that although the COVID test itself is paid for, the visit for you to have your symptoms checked and diagnosed is not necessarily free, especially when you don't have a COVID diagnosis.
Okay, thank you. So yeah, I guess one of the things, so thank you for that. That actually was very helpful. I guess one of the things that I've heard that is a frustration for some of the employees is if they, they're working 5 or 6 days a week and they're told that they have to show up on one certain day outside of that schedule is burdensome for these folks. And so I think that was also one more element that I've heard previously.
And that is why we've moved them towards self-directed testing, exactly for that reason, is that when the facility controls when and where and how they test the employees, then if you miss, we do 100%, they're going to do 100% of their staff 1 week of the month, and then the other 3 weeks they get to pick a random 10%. If an employee is on vacation for that one time a month that you're testing 100%, you can pull them into your 10% segment for the following week, and you can choose when to do that. When we were running the testing program, we did not have the flexibility to say, you don't want to test on Saturday, so we're going to schedule you for Wednesday, because our labs, all of our labs, Dartmouth and Public Health Lab, have capacity. The very first week we started our program, the facilities we assigned on Saturday and Sunday independently decided that they were going to test on Friday instead, right? So our goal is to have anywhere between 500 and 750 lab samples come to our lab per day. Because of that first week, we ended up with something like 2,500 lab samples on our doorstep on Friday, because they didn't want to test on the weekend. It created a massive backlog in the lab for the entire weekend, and that's why we didn't have that flexibility. So moving to self-directed testing gives the facility that flexibility to test whenever they want.
And that does make sense, but from from if it was me, you know, and I work 40 hours or whatever a week, and then I have to take care of my kids and I have to go get a test, and I'm not going to be, you know, how am I supposed to, I'm just trying to think about the logistics of employees having to be told they have to go get the, look, this is not an easy solution, and I'm, you know, or there's no easy solution here. And I'm just offering you what I've heard from constituents and from other folks is that it is challenging, right? And my fellow committee members can attest to my own struggles just sitting here in front of a computer, trying to balance, you know, my 3 kids and the craziness that's involved there. And all I have to do is sit here. But I can imagine the difficulties. Sorry, go ahead.
The beauty of the self-directed testing program is that if the facility chooses on the week that they're going to test 100% of their staff to test some on Monday, some on Wednesday, some on Friday, then they can do that, right? They're right there. They're pulling the specimens, right? So that is the flexibility they have. They have to just contract with the lab. Many of them contracted with Quest, right? Quest or Nordics or Mako. All of those labs have couriers and pickups in our state multiple times a day. They do business with all of our hospitals, with our nursing homes, with our private physicians. So they can arrange that with their lab, that they can do it multiple times a week if they want to, so to take care of exactly the situation you're talking about. We just did not have that flexibility when we were doing all the facilities.
Sorry, I'm dealing with a virtual school situation. It was exactly what I was just referring to, Commissioner. I'm sorry to cut you up in it too. So my next question is, Representative McMahon, please do feel free to just jump in on this question. This is Senator Ward's question, and she regrets not being able to be here, Commissioner, but I asked if she had any questions that she would like to pose to you, and the question was around reimbursement rates for long-term care facilities, and I think Representative McMahon, correct me if I'm wrong, but the discussion was both in terms of being able to more adequately provide availability of single rooms and staff employee attracting and retaining staff, which we know, you know, COVID or not, has been an incredible challenge for the entire healthcare community in the state of New Hampshire, but obviously things are exacerbated under the current situation with COVID. So, Commissioner, if you could just briefly talk about your perspective on increasing reimbursement rates, what can be done, what either at the, I know a lot can be done at the federal level. Are there other things that we can do at the state level to ensure that our long-term care facilities have the adequate reimbursement rates in order to attract and retain staff, and also to move in the direction of being able to equip our facilities with greater access to single rooms?
So reimbursement rates are largely a state issue, not a federal issue. The federal government pays half the Medicaid rate, and the counties pay the non-federal share up to a cap in New Hampshire. So all of our representatives, you all sit on your county nursing or your county delegation, and you hear about this all the time, right? Is the non-federal share of the nursing home reimbursement comes from county. So, you know, from the state point of view, the budget issue, the budget amount is fairly small. We pay everything over the cap. So to increase reimbursement, we would need to put more money in the budget. Counties would need to put more money in their budget, and we would need to increase the cap and increase reimbursement rates. It's truly a budget issue. Right now, we have increased FMAP payments, which is basically the federal share of Medicaid, and that has been that's during COVID, and we've passed that down to the nursing homes. And reimbursement rates in long-term care has been a struggle for at least the 20 years that I was in nursing homes. And this was before counties had the non-federal share and after counties had the non-federal share. So reimbursement rates in nursing homes is simply a budget issue. And I say simply, and I know it's not simple, because it's not just state budget, it is also county budget. So if there is a bump in rates, there has to be a bump in the cap, and that is going to hit the county taxpayer dollars.
And given your expertise, would you assess that an increase in rates would support increased employee retention and support attracting new qualified employees as well as move us toward more individual rooms?
So two things on that. It depends on how every facility would use it. Would they pass down rate increases to employee wages? I would say that some would, some wouldn't. The vast majority, I think, would increase the pay rates, but even facilities that have very competitive pay rates still have a hard time recruiting and retaining staff. The idea of single rooms is interesting. Number one, moving to a single room model becomes a capacity issue in our current buildings. If the vast majority of our facilities are semi-private rooms and you cut all of that in half, we're going to have issues with just having enough beds in our state. The newer buildings that were built, and I think Cheshire's in there, and Merrimack County, Grafton County, Rockingham County, Carroll County, all building newer buildings in the last 10 or 15 years. I had the opportunity to be on the design team for Merrimack County Nursing Home when we built the new facilities in Boscawen. And inherently, many residents like the privacy of a private room, but there are also a very big subpopulation that do not, because as much as it is private, it is also isolating, because you don't have the roommate there to have conversations with and just to kind of share things with. So we built private rooms into the new facility, but we did not build an entire building of private rooms. I think there is a preference there on whether we assume, because we don't live in a nursing home, that everybody wants their own room. And I think what you find is when you get into the nursing home, that you don't see as many residents with that preference as what you think that you would. You have some that very clearly love having a roommate and love the social setting of the nursing home. And it just depends on how it's designed. The old style semi-privates is very challenging, where you have one bed against window and one bed against the wall or the door, and we always call it the window bed or the door bed. It's tight quarters. It's not the best environment, but that's what you see in facilities that were built back in the 70s and 80s. When you come to facilities now, if you ever get an opportunity to tour Merrimack, we built it so that every bed has a window, and that made a huge difference to be able to have your own space to grow plants, to look outside, all of those things. So I think the private only rooms is extremely challenging because of capacity issues, and I don't know it's what every resident wants. Now, as our next generation comes, as we all age, right, and we go into
I was going to say, is the next generation, is that us, Commissioner?
That is us. That is us coming into nursing homes. There's a lot of things that are going to change because socially, we function very different than our 80 or 90-year-old parents, grandparents. Things like, if you recall, back when I first get into nursing and get into nursing home, we bathe residents once a week. They loved getting a tub bath once a week. That is completely not acceptable anymore. People could take showers every day now, right? So So as things change in society, we see nursing homes needing to change. Now, as we get closer, our generation gets closer to nursing home age, will there be more call for private rooms? Probably. I think that we are probably going to want that privacy more than the generation that's ahead of us. I think it's just an evolution of how we are.
Excellent. Thank you so much for that insight, Commissioner. So my last question, and this is not, I want to be exceptionally clear. This is not a criticism. This is a serious question. I saw that that you announced we had 4 more deaths in our long-term care facilities as a result of COVID in the union leader this morning. Is there anything else that you would like to see us doing? Are there any legislative policies that you would like to put forward in order to effectuate any additional changes or supports that the department needs to keep our employees and residents of long-term care facilities safe and well?
So, when I look at the intent of this group and this committee and what change you can effectuate, the vast majority of what you've been tasked to do is already done through our federal rules, our laws. We audit all of our facilities. They are required. If you look at our CMS regulations that that guide our nursing home operations, almost everything that you've been tasked to do is in those regulations, that the facilities have been required to meet those standards for decades. What is within our state control is our licensing guidance, but to be honest with you, our federal guidance is way more stringent than our licensing guidance, and I don't think that you're ever going to get more stringent than what the federal guidance is. I mean, it is very, very strict, the federal guidance for long-term care facilities. What you do have control over is reimbursement, and that's through the budget process and through your county budget process. So those 2 components, it's not just state budget, it's also county budget. So that's probably where you have the most area of control, is over things like reimbursement rates, stipends, enhancements. Anything that's monetary that comes from state and county is probably where you can have real impact.
Great. Well, thank you for that. Are there any final questions for the commissioner? She's been incredibly generous with her time. Great. Well, Commissioner, really just to express the gratitude of our committee, thank you very much for joining us this morning. We're very grateful.
No problem at all. And if any of you have questions that I did not answer, feel free to email me or send them through Senator Morgan. I'm happy to answer by email too if anything pops up that you forgot to ask.
Thank you so much.
Have a great day.
You too. Okay, committee members. So Representative Birch, we had paused in the middle of your while you were speaking, and I apologize for interrupting you. Would you like to finish that thought that you had, which I don't recall what it was, but.
No, I think I got across what I needed to. I was talking about testing and costs, and
right.
I think the commissioner actually spoke quite extensively about that.
Great. Further discussion on the report, the draft report? All right, well, seeing none, thank you so much, everyone. I know this was a longer meeting, but this was a very helpful meeting for me, and I hope it was for you and for members of the public as well. Let's just open it up to the public for a minute here if they have any input. And I just would like to remind everybody that we are on a hard stop in about 10 minutes. So if there is any input, we would more than welcome that. But just due to the Zoom platform and scheduling, we have a hard stop. Can we open it up to public?
Yes, Senator, if anybody in the public who is watching would like to participate and speak, please raise your hand digitally via Zoom, or if you're on the phone, you can press *9.
The chair calls Cheryl Steinberg. Ms. Steinberg, you're muted. Oh.
Faster to unmute on our end, Senator.
Okay.
Oh, sorry.
There we go. We can hear you now.
Oh my God, it's so annoying. Okay, apologize. Sorry, my name is Cheryl Steinberg. I'm the director of the Senior Law Project at New Hampshire Legal Assistance, and I'm also involved in the advocacy efforts on behalf of the New Hampshire Alliance for Healthy Aging. I just want to say, we've been very concerned about, all the deaths in the nursing homes and also the isolation too. And I mean, I know your committee has clearly covered all that information very extensively, and we appreciate all the work you've done. I just wanted to point out this issue about funding the nursing homes. There's no doubt that more funding is needed, but our concern is the current home-based system for home and community-based care is so underfunded compared to nursing facilities. And the one thing that we've learned in this pandemic is that it's safer for people to be in their homes than it is to be in a nursing home. I don't know if there's any clear statistics on those who are receiving services under the Choices for Independence program, but all I can tell you just anecdotally, who I've spoken to with CFI case managers, et cetera, they don't know of anybody that they've been serving that have died because of COVID-19. Where we have, obviously a much higher death rate in facilities. I understand there's always going to be a need for facilities. I'm not saying that we just do away with them, but there's such a gross imbalance right now. And in our view, I think we feel like the way to keep people safe, the best way would be ideally, to the greatest extent possible, would be to keep them in their home and provide the supports and the funding needed to really help them stay there. So I know that's beyond the scope of your committee's charge, but what we'd really hope that you could say, maybe as a recommendation, is that really needs to be looked at down the road. I mean, as you know, we're the second oldest state in the country, and our population of aging people is only going to get bigger, and we really need to figure out how we're going to serve everyone, as you're saying yourselves, me, I'm 60, it's happened, how are we going to do this? Because it isn't by having everybody go to a nursing home. I mean, I think we need to, think about, just not accept that that's the default, that's where people have to go when they get older and need help. I mean, so I guess that's all I would really ask the committee to think about, if you think that's appropriate to include in your report, is something to have a really, extensive look at that, and how we're going to reconfigure the system so that it does serve everyone in a good way and keep everybody safe and have the right socialization that's needed that can't always happen in the nursing facility, particularly in the light of a pandemic.
Great. Well, thank you so much. I really appreciate it.
No problem.
Questions from the committee? Anyone? All right, seeing none. Thank you, Ms. Steinberg. Further input from the public? The chair calls Mr. Gary Cahoon. Mr. Cahoon, thank you for joining us, and the floor is yours.
Thank you very much. My name is Gary Cahoon, and I'm the owner-operator of Friendship Manor, which is a small residential care facility. We are members of the CFI program. We provide care for 21 residents. 19 of whom are CFI recipients. And I would like to second what Cheryl has just said. There's no question that the nursing homes in the state are underfunded. There's also no question that the state over the last 25 years has rebalanced in the sense that it has moved people out of nursing homes into community-based settings. But the reason that we're not fiscally balanced still is that we underfund drastically, haven't really provided the facilities to care for people in the community. We move them into the community without sufficient supports in many cases. And so I would just like to second what Cheryl has said. There is a need to fund CFI at a much higher level than it is. And it's not simply a matter of rates. It's also reaching out to provide services for people who are not currently receiving them. The state can quantify the number of people who are not receiving home health services who have applied, but there is no quantification of those that the state can provide for residential care services, because people aren't identified as residential care candidates until they have found a placement. They're simply CFI. So there's tremendous lack of CFI residential care beds. Of the roughly 6,000 assisted living beds in the state, only about 500 are CFI beds. The need for CFI beds greatly exceeds that. So I just like to thank Cheryl for what she just said. And there's one other point I would like to make, and that is on staffing. We have a staffing issue at Friendship Manor, like every other long-term care and assisted living facility in the state. And it is not simply clinical staff. Our biggest need right now is kitchen staff. We need cooks, we need dietary aides, we need activity people, and we cannot hire them. The department has gone to great lengths to address the clinical needs, but it's also the ancillary needs or the ancillary staff, which is a critical need at this point. And that's all I have to say. Thank you very much.
Thank you, Mr. Cahoon. Questions from the committee? Mr. Cahoon, and I see that Cheryl Steinberg is still with us on the call or the Zoom. If either or both of you would be willing to submit to us, you can send it to me or Cameron, the talking points, or what would be most helpful is data backing up some of the issues that you raised with us, particularly around staffing, Mr. Cahoon, that and reimbursement rates for in-home care needing to be increased. Any hard data would be really helpful for us, either research papers or other material that the committee could use to reference in its final report. Because I'm sure that while the committee's charge is long-term care facilities specifically, this obviously dovetails with that very closely. So we'd welcome that.
Thank you. We'll see what we can do. Perhaps I can speak with Cheryl and we can put something together.
It doesn't have to be extensive, but something that would just point us in the right direction would be helpful. Thank you so much.
Thank you.
All right. With that, I welcome the public. We're at our hard stop, unfortunately. If the public has any further input, please know that we more than welcome it. And in fact, we encourage it. And you can send it to Cameron. Cameron, will you share your email with the public so that they can email you just in case they do have any additional input?
Yep. So my email is my first name dot last name. So that's CAMERON.LAPINE at leg.state.nh.us.
Great. Thanks, Cameron. And I would welcome I would welcome a motion. Sorry. Thank you, Representative Birch, and seconded by Representative Stringham. Representative Birch, how do you vote?
Yes.
Representative Stringham?
Yes.
Representative McMahon?
Yes.
And Senator Morgan's a yes. Thank you all very much, and we'll see you back here, correct, on the 22nd at 9 a.m. Perfect. All right. Have a good one, everyone.